Dr. Reddy is there? Okay. Dr. Gokul Reddy, he is from the Citizen Hospital, Hyderabad. He will present the percutaneous aortic fenestration of acute aortic dissection.
Good afternoon to you all. We have a strange situation 6 months back. A 29-year-old guy, no risk factors, non-hypertensive, non-diabetic, non-smoker. He was accounted in a supermarket, had a severe back pain in the morning, went to his physician, blood pressure was high. The physician suspected something in the dissection because he had back pain also. He referred to the cardiologist. Cardiologist saw him, diagnosed dissection on echo, and referred to our center. We do slightly higher volume of cardiac surgery for dissection of aorta. That's the reason this patient landed with us. He came at 5 o'clock in the evening. The blood pressure presentation was 250 by 140. He's admitted. We started labetalol, nitroprusside for pain relief. It was severe pain actually. We gave fentanyl. On examination, there was no pulse on the right leg, absent femoral, dorsal pedal. The right leg was cold. He was in severe back pain. Leg pain was numb and painful also. We did a CT immediately. We showed a type B dissection acute with entry point just below subclavian and no exit here, and no flow into the leg artery system. So this is the CT. You are able to see the one leg artery, the second leg artery is missing. The entire thing is the dissection. Only the center is the true lumen. So this is the slice of CT. You can see the dissection flap here. Dissection flap is seen here. Then again you can see the same flap in the thoracic aorta. Here you are able to see the red arrow shows that the distal bifurcation at the arterial junction has a thrombus. In fact, there is no flow in the right iliac system. This is a contrast CT. The white thing is the left iliac artery. So surgeon was the first on call. He saw the patient. He said the type B acute dissection with the leg pulse not there. It's a very big job because from subclavian to the aortic junction, it's a big surgery. He said the mortality is close to 70-80%. He would not do it because of the compromise of the leg. The only choice was to relieve the pressure inside. We checked literature. We had a couple of descriptions in the book saying that it can be punctured by the simple wire or a broken burrow. We never did it, but we explained everything to the patient, and we made this hardware ready: a sheath, a regular wire, a 4F diagnostic, a 730 peripheral balloon, amplifiers 0.25 stiff, a Fogarty and broken burrow, standby. Our plan was to poke with a straight tip wire. If it doesn't yield, we were ready to do a broken burrow. So this is the first picture. We actually cannulated the left femoral artery because there is a true lumen. We passed a 3-5 wire in the true lumen, then took a JR4 catheter and exchanged the wire with a straight tip term of 0.21 wire. We actually poked at the false lumen. False lumen is a very high pressure, 250. It's actually ballooning. That's the reason we're able to see the pulsation also. With subtle perseverance for 3 to 5 minutes, we're able to enter the aorta. Pictures I think we'll be able to see. Here we are trying with the wire. Slightly, we tried to push the catheter, but it doesn't go. We actually made the wire into a loop and advanced further up. It took almost 3 minutes for us to enter. Then we entered the wire in. Then the catheter easily slipped inside. From here, we wanted to check whether in the true lumen or probably sometimes in the, out of the aorta also. The injection shows a contrast is staining in the lumen. This never happens in aorta, not in the outside. So this lateral AP, in both the contrast is staining, is a false lumen. We're very sure. Then we exchanged the wire with a stiffer wire, 0.25, because the peripheral balloon would not go on a 0.21 wire. So ampereage stiff wire was taken. We took the 730 mm balloon and dilated the entire thing. Post dilatation, there was some trickle of flow in the right leg. Able to see a small drops of flow in the right leg, but still it's not a good flow, probably TIMI 1 when you say coronary correlation. Then we entered selectively the artery. When we injected, there's a big thrombus in the right leg. Then we called the surgeon in again. Plan was to do a Fogarty. We did a Fogarty, this Fogarty catheter balloon. With the cut down of the femoral, we introduced the Fogarty, then slowly we took the clot out. And after the removal, you can see a beautiful flow in both the legs. There is no residual thrombus also. Entire thrombus has been removed. This is the entry point where the surgeon did a cut down. This is a cartoon diagram. This is entry tear. Then this is a big bulge within the red sac. Then this the leg was totally cut off. And this is the bulge where I was mentioning the bulge is there. There we wanted to poke. Then with the wire inside, we went the balloon dilated. Post, this is the kind of the thing what we got. Entry point, exit point, and a double lumen. So this is the picture when no flow was there. When the Fogati was removed, he had a full jet of flow. There's a gush of flow. It was fully ischemic. Then the CT was done on 7th day. Both the legs are reformed. Both the arteries are normal now. This is a CT which done probably a month later. We have aorta which 4 centimeters, and this exit point is clearly seen. So both the iliacs, now you can see a normal flow here. So you manage ICU for next 72 hours, required laboratory SNP for next 40 hours. He discharged on day 7. The aortic diameter at discharge was 3.6 of 4 basically. So right now he's doing well on 3 medication, BP 120/70, labetalol, amlodipine, clonidine are the drugs. What he's using now is absolutely comfortable. We did a CT last week just for the presentation's sake. He had aorta of 4.8 centimeters of maximum diameter. The guidelines say that if the diameter is beyond 5 or the progression less than 1 year is beyond 4 millimeters, he requires EVAR. Probably we advise EVAR for him. If he's financially comfortable, might plan for EVAR. Thank you.
Presentation. Actually, any question from the?
Why didn't you attempt to close the entry point so that the false lumen would collapse and you would have got the...
Yeah.
Entry point would require a covered stent and not on the shelf. We need to go to the hand. It is covered stent, and it's never on the shelf in the hospitals. We need to, when patient was acute pain, winter time. The only option available was to decompress the false lumen.
Apart from the lower limb, was there any other arteries involved
the
in it?
kidney, right kidney was gone. One of the mesenteric was gone. That's the reason surgeon refused to touch. When mesenteric was not there, right kidney was not there. Both were in the false lumen.
How was the result after this?
So he's doing well, absolutely. Kidney, right kidney is 90% infarcted still. But left is now created 1.2.
No malperfusion syndromes.
No, he's a stout fellow, 5'7" and 80 kilos.
And he didn't have mesenteric ischemia.
Yeah.
He didn't have. We're lucky, he didn't have. Because false lumen was open, it's a double lumen kind of thing, the flow was still going to the mesenteric.
But because it's distal to the left subclavia and extend up to the end of the
That's true.
iliac
Iliac,
artery.
big stent
So that case, just like a type B dissection like. So in that case, with a stent graft, long stent graft can be given. Dr. Khan has done a couple of cases, even though he has done one case
He's the right
in
judge
hospital.
to say.
Short lifting.
I was saying something different, if you go from the subclavian or from the top, your wire would be going to the true lumen. The way we do fenestration is that it's easier when you get a wire into the true lumen. Like in this case, you couldn't go from below.
Because the leg was not involved, basically.
Yeah.
It was, CT showed that entire thing, left leg is right, is not left is not
There
involved.
was a rent near the below, after the subclavian, and the wire
There was,
would have slipped into the true lumen.
That's true.
What we do is, wherever we want to puncture, on the wire we take a peripheral balloon, inflate the balloon in the true lumen, and then take a broken barrow from the false lumen and just directly puncture the balloon.
Okay.
So that way your wire is not going to slip. It is going to go into the true lumen and there's no risk of perforating the aorta. We find that's the safest way to do in situ fenestration.
But it took 5 minutes on table and the only thing was we did the Fogati because of the occlusion.
No, Fogati is the right thing because there is a clot, you have to
That's
take it
true.
out. But I'm just for the people, I'm telling the safest way to do a fenestration would be this. Sometimes you may not have a bulge like this,
That's true.
and it's difficult
true.
to actually
That's
perforate and make a fenestration.
That's true.
Fortunately, your renal arterial ostium, both the side not affected. So that is a great problem for this thing.
Both have to lucky patient
Yeah.
operator.
Okay, thank you very much.
Thank you.
Then Amit is there? Okay. Amit from the Sri Jayadeva Institute, Bangalore. So he'll present the innovative use of the broken barrow needle in endovascular revascularization.
Of
Your
central
center is broken barrow needle commonly used. Apart from that, so many other use you will want to
In this
present.
case,
Okay, thank you. You present it.
Good afternoon, respected dignitaries. I'll be presenting a case of use of broken barrow needle in endovascular revascularization of central venous occlusion. Our patient was a 55-year-old female who was a diabetic, hypertensive, and known case of chronic kidney disease on maintenance hemodialysis through AV fistula in the right arm, who presented to us with 8 months history of swelling in the right upper limb, neck, and right side of the face for the 8 months duration. There was failure to perform dialysis through the right AV fistula due to severe venous hypertension for the past 3 months. Meanwhile, she was being dialyzed through a catheter in the left femoral vein. On upper limb examination, there was swelling in the right cubital fossa measuring 12 into 10 centimeters, which was due to aneurysmal dilatation of the AV fistula, extending proximally to the axilla with fullness of the supraclavicular fossa and dilated veins over the upper chest, suggesting formation of collaterals. And there was swelling over the face with dilated veins over the cheeks on the right side. This is the picture. The lady, we can appreciate the swelling in the right cubital fossa, extending up to the upper arm, and they can also appreciate the fullness in the right supraclavicular fossa, as well as dilated veins over the cheeks. Her routine investigations were suggestive of CKD. ECG and echo showed features of left ventricular hypertrophy with normal LV systolic function. Then we subjected her for a CT venogram, which showed the distal confluence of the internal jugular vein with that of subclavian vein having a 60 to 70% compromise in the lumen. And except for the cranial 13 millimeters of the right brachiocephalic vein being patent, the rest was occluded. The rest of the vessels and the veins on the left side were patent. This is the CT image showing a complete cutoff in the right brachiocephalic vein. So then we planned for a conventional venogram with aim to revascularize endovascularly, because that is the first line recommendation as per the National Kidney Foundation guidelines. Since it was a complete occlusion, we decided to go through the retrograde approach in the right femoral and femoral artery and the vein axis. Through the right femoral artery, we first introduced a JR catheter into the subclavian vein and an arterial chute through the power injector. Excuse me. Yeah, the first video shows the arterial injection to the power injector in the levo phase. We can see the cranial occlusion of the subclavian vein. Yeah, there we go. And through the right femoral vein, we introduced the multi-purpose catheter to see the caudal end of the occlusion. There we can appreciate it is completely occluded. Then through this multi-purpose catheter, we tried to pass a termo wire, angled termo wire, in order to negotiate the occlusion, but we were unable to do so because, as we can observe, the multi-purpose catheter is not providing sufficient support for the termo wire. So to overcome this, we then took a long sheath, a Cook sheath, which would give a firm support to the guide wires to negotiate through the lesion. In the second and the third video, we can appreciate the angled as well as the straight hard end of the termo being unable to negotiate the lesion. So then we decided to go through the antegrade approach through the right cephalic and the subclavian vein. So in this we can observe that after the guide wire we pass the multipurpose catheter again, and the simultaneous injection from both the ends revealed that there was a short segment complete occlusion of the right subclavian vein. Next, our plan was to introduce the termo wire through the subclavian vein catheter and snare it down from below. Now these are the videos which showing the same. In the third video, we can see that the termo wire appears to be have negotiated the cranial end and appears to be in the lumen. Now before snaring it, we have always confirmed with the lateral views whether to see whether it is in the true lumen or in the false lumen. Now this is the video which shows that the wire is outside the lumen and not in the true lumen, hence snaring was not possible. Despite repeated attempts, we were not able to enter the true lumen. And since we had used a lot of contrast till this procedure and all, the procedure also had taken close to an hour, we decided to abandon the procedure for that day with a plan to do needle recanalization in the next attempt. The same was communicated to the patient regarding the risk of vessel rupture or puncture, and also the possible need of a surgical revascularization was communicated. So in our next attempt, we first initially secured an internal jugular vein access and placed a sheath there which would act as a guide to guide the broken burrow puncture. In the second video, we can see that we are advancing the broken burrow needle, keeping the IJV sheath as a guide, and after passing the occlusion, just to confirm, we give the contrast injection. In the third video, we see that we have crossed the lesion and entered the cranial end of it. And once this was done, we initially passed a 018 termo wire through the Mullin sheath after taking out the broken burrow needle in the first video. Yeah, you can observe there that after the thermo wire had been passed, we exchanged it for a amplad super step wire, and on that we did serial dilatations, initially with 8 into 40 Atlas balloon, followed by 22 into 40 Atlas balloon. We went up to 30 to 35 atmospheres, 36 atmospheres, and kept the balloon inflated for 10 to 15 minutes. The last video shows the final result, wherein there is a brisk venous return after an arterial shoot. This is the pre-procedural image, and beside that is a post-procedural image which shows complete recanalization of the occluded brachiocephalic vein. This would be regarded as a technical success, which is defined as a procedure without significant residual stenosis. Central veins are notorious to have elastic recoil and residual stenosis following plain balloon angioplasty. And this was the follow-up image after 2 weeks procedure. We can see the swelling over the face and supraclavicular fossa has come down, although the swelling in the arm would take some time because it is because of the aneurysmal dilatation of the AV fistula. Very briefly about central vein stenosis, which is defined as 50% or greater stenosis involving the internal jugular, brachiocephalic, subclavian or the axillary veins. For lower limbs, the iliac and the IVC are regarded as central veins. Incidence of central vein stenosis is about 25 to 40%, especially in CKD patient. The mechanisms are prolonged central venous catheterization, especially catheterization to subclavian vein has an incidence of around 50% as opposed to IJV, which is only around 10 to 15%. And also due to the high flow status of the AV fistula or graft, subsequent causing venous intimal hyperplasia and stenosis. Now, what are the common indications to intervene in a central vein stenosis? Cerebral venous hypertension, symptomatic arm, neck or face swelling as in our case, prolonged bleeding after dialysis because of venous hypertension, progressive aneurysmal dilatation of the axis thrombosis. Now there are two ways, the endovascular or surgical. Based on the National Kidney Foundation Disease Outcome USA, the recommended first line treatment is angioplasty with or without stent placement. Now whether to stent or not to stent a lesion, especially nowadays with price capping, stents are not easily available. And also the first line recommendation would be a plain balloon angioplasty because it has also got a reasonable patency rates at 1 year of as much as 50 to 60%. And stent placement is recommended only if there is elastic recoil of the vein which leads to residual stenosis, or for lesions which recur within 3 months after angioplasty, or in case of a complication as in vessel rupture. So to conclude, central vein stenosis or occlusion in patients undergoing hemodialysis is a common or difficult problem to treat. Avoidance and minimizing the duration of central venous catheters is of utmost importance. And last slide please. Can I have the final slide? Last.
Anything?
Somebody else is operating, isn't it? See?
Okay, you can conclude.
To conclude, sir, although uncommonly used for central vein stenosis, broken barrow needle can be very helpful in tough fibrotic occlusions as in our case. When other routine methods like thermo or O35 guide wires are not able to negotiate the lesion, because a failed endovascular approach would mean that the patient had to be referred for a surgical revascularization, which has got significant higher morbidity and mortality, and also the patency rates are comparable with that of endovascular approach.
Okay, thank you very much. It's just like a superior mediastinal syndrome like features, no? Sometimes, no, just reverse way, when the obstruction on the IVC, no, they are also Burchieri syndrome like features. So that case is IVC membrane should be dilated by the broken barrow needle, and then question of stenting also controversial. Similarly, you have done this way. Yes. Nice job, you have done it. Any question from this?
Did you try the backhand of the side wire?
Thermo wire, yes sir, we did. Glide wire, the backhand was initially tried in our first attempt, failing which then we decided to do the needle recanalization.
Very nicely done case of Praveen. I have a query. How would you explain that earlier you were dealing with the straight and the harder end of the thermo wire going through the veins?
But
because this is an arterialized vein with a high pressure, but you didn't have any bleeding complication because it
No,
was in the false
we didn't
passage.
we didn't appreciate any bleeding. In such case, we have to keep a covered stent or a bare metal stent ready to teach.
Normally, if you perforate with a wire and go outside the vessel, I mean, especially in the venous central vein, bleeding would never happen because it's a very fibrous structure around the vein also. There's no flow anyway. I mean, it's a CTO, there's no flow anyway.
Already
If you
chronically
dilate,
affected.
then there is a problem. If you like dilate and snare and then start putting balloons and catheters, then there would be a problem.
Thank you, sir.
Okay, Arvind, thank you very much. Next speaker, Dr. Arvind Khandonia. It is there? Okay. He presents with percutaneous trapping